COVID-19
Recording in
information for the
progress.
Amarillo community. Let me go ahead and introduce who's on our panel today. We're joined by Casey Stoughton, City of Amarillo Public Health Director, Dr. Todd Bell, Public Health Authority, Texas State University Health Sciences Center, Dr. Michael Emmentier, Chief Medical Officer for BSA, and City Manager Jared Miller. We'll go ahead and open it up to our panel for opening statements, and then we'll take questions from our media who are also in attendance. We'll start with Casey Stoughton, Public Health Director for the City of Amarillo. Casey, how are you?
Good morning. I'm good. It's nice to start to be feeling those fall temperatures. I forgot to take a coat for my little one, and she reminded me of how cool it is on these nice fall mornings. And so I hope that that you're enjoying that too. I know that we are at our house. So we'll start with our numbers, and then we'll talk about the goings on at all of our clinical services, and then we'll pass it on to our other team members here on the call. So I'm glad to be here with you this morning. As of yesterday, there were a total of 46,504 cases of COVID-19 reported in Potter and Randall counties. We're currently at 2,182 active cases, and we do have 902 deaths here in our community to report this morning. The 5-day new case average has dropped to 111 new cases per day. Yesterday, our GA34's hospitalization percentage was at 12%, so we're no longer considered an area of high hospitalization, but we are still in level red. Currently, 3 of the 4 metrics are in level red, but the numbers are looking better each week, so we are hopeful that that we'll be able to change that that level soon. So while we're still in level red, though, it's important to remember all of the prevention efforts like masking, social distancing, good hand washing, and always vaccinations. The 7-day rolling positivity rate is currently at 11%. The positivity rate at our drive-through testing site is currently at 27%. COVID testing is still available, and the phone number is 378-6300. I hope you have that phone number either memorized or in your contact list by now, but you can call that number and be screened and directed to the test site. The drive-through testing site has moved back to the old Coca-Cola warehouse there at 801 South Lincoln, and testing is by appointment. COVID vaccinations are also available in many locations around our community, including public health. Currently, we're offering vaccinations at 850 Martin Road, and that's the building just right next door to our public health department. STD, TB, and regular immunizations are available at the public health department at 1000 Martin Road, and those are available by appointment. You can call that same 378-6300 and schedule an appointment. We also have the monoclonal antibody infusion clinic still open. That is also by appointment. And since the infusion center reopened on September 22nd, we've seen 591 patients. So 591 patients in just under a month. So we've certainly had a lot of interest and seen a lot of patients through that clinic. So that's been a great service here in our community. If you're positive and high risk for severe complications of COVID, or if you are a contact to a positive and a high risk individual, if you've got high risk complications like obesity, or if you're over the age of 65 or some high risk condition, we certainly want you to be able to have access to the monoclonal antibody treatment. So talk to your doctor about a referral, or if you don't have a doctor or you need a referral, please call your favorite phone number, 378-6300, and we'll be happy to assist you with that referral. Physicians and providers here in our community or in the Panhandle region, we did send out a health advisory with referral instructions. If you did not receive this information, we want you to have it. So again, please call 378-6300, and we're happy to send you those instructions. That's all I have today, Dave, and I really appreciate this time.
Thank you, Casey. Let me go ahead, and we also have another panel member here before I go to Dr. Bell. We have Dr. Catherine Ewing, nurse executive at the Amarillo VA. So if the media has any questions for the Amarillo VA, she is here to be able to answer any questions. We'll now go to Dr. Todd Bell, Public Health Authority, Texas State University Health Sciences Center. Dr. Bell, how are you?
Doing well. Thank you, David. Appreciate the opportunity to be here. I guess, first of all, just a little bit of comment, kind of following up with Ms. Stoughton about the numbers that we're seeing from a community transmission standpoint. What we see is that the numbers are trending down. They're trending down slowly. That wonderful fall weather that we all look forward to typically means that we tend to get together into indoor places. That increases the risk of lots of viruses like flu and RSV and things like that we've seen kind of out of season. That may actually kind of prolong a little bit our transmission of COVID. But again, our general trend of numbers are that they're improving. And I remain very optimistic about the way the holidays are going to be looking here in Amarillo, and that our numbers will continue to trend down. That doesn't negate the fact of the importance of things like the vaccines and making sure that we're protected. And if you're in a high risk situation indoors with in public spaces wearing masks, all of those things are going to continue to be important, as is getting the flu shot. With the COVID vaccine, there's a few things that are in process right now. People may have heard about some additional authorization from a booster standpoint, the Moderna booster. That was authorized by the FDA, but we're still waiting for the ACIP recommendations, which I believe happen later this week. We'll hopefully know by the end of the week what the formal recommendations are for the use of Moderna booster, if I have my timeline right. We also have a vaccine that will likely be reviewed next week by the FDA for children between the ages of 5 and 11. It's worth bearing in mind that as the coronavirus has shifted, as we have this new Delta variant, that kids that early on in the pandemic did not seem to be at real high risk of getting coronavirus, now with the Delta variant, they do seem to be at significant risk of getting COVID. We think that the majority of those infections, maybe 50%, maybe a little bit more, are asymptomatic, meaning that the child may not actually have much, if any, symptoms, but they still are able to share that and spread that to other children and teachers and grandparents and parents. And so as we look at our community as a whole and how do we keep our community healthy, we want to encourage people to look at vaccinating their children, and specifically when we get the additional data that's coming out over the course of the next few weeks. So we'll be keeping an eye on that information about vaccines. I believe Dr. Weiss is not here today, and he was kind enough to share some of the numbers from Northwest. So I'll go ahead and run through these. First of all, I believe this is as of this morning, we have 38 in the hospital at Northwest. That's the first time that we've been below 40 COVID patients in the hospital in the past 2 months. Of those 38, about half, so 17, are in the ICU. Of those in the ICU, 15 of the 17 are unvaccinated. Only 2 of those in the ICU are vaccinated. We have 18 on the med-surg unit, that's just the regular floor, of which 13 of the 18 are unvaccinated. We also have 2 COVID patients that are in the neonatal intensive care unit. We currently have 22 ventilators in use over at Northwest, of which about a third are being used specifically for patients with COVID. Our testing positivity is about 6%, and it's been in the single digits over the past 2 weeks. So far this month, there's been 10 patients who have unfortunately died from COVID this month in the Northwest numbers. Northwest also has currently 17 staff that are quarantined. And as we approach the end of the month, the ancillary staff, those traveling staff that have been mobilized to be able to help with staffing our units in the hospital, it's anticipated that they'll be winding down their contracts by the beginning of November. Hopefully that'll coincide with ongoing decreases in the hospital pressure from COVID patients over the course of the next 2 weeks. That's all I have, David.
Thank you, Dr. Bell. We'll now go to Dr. Michael Lementier, Chief Medical Officer for BSA. Dr. Lementier, how are you?
Good. Thanks, David, and good morning, everybody. I'll give you guys a quick update on where we are numbers-wise, and then a couple other updates. First of all, we have about 272 patients in the hospital today to start the morning. And of those 272, 53 are COVID positive. We started to really decline slowly in our overall COVID inpatient census back in the midsummer from where we were in that 80 to 90 range, and then just slowly kind of dropping off. And we're just anticipating and hoping to see a more rapid decline in those numbers, but we're just not seeing it. We've dipped into the 40s over the past week, only to be back up into the low to mid 50s again. So this may be a more gradual decline in the overall inpatient census. We hope that it's going to be the ongoing decline, as has been discussed in our predictions. But the key piece here is going to be the more people we get vaccinated, the greater likelihood of having diminishing hospitalizations. Of those 53 we have in the hospital today, 24 are in the ICU proper, 27 are ICU level, 3 of them are in our intermediate care unit. And because of the shifting around of our ICU patients in terms of accommodating these patients in a cohorting fashion, we have to have some of them in our intermediate unit. We have about 19 patients on our med-surg unit. We have 1 pediatric patient currently. There was also a patient coming in through the ER this morning on our early look at the numbers. 20 of our intensive care unit patients are on ventilators at this time. And that number has continued to be a pretty consistent percentage of the total that are in the ICU that are requiring mechanical ventilation. We're still seeing anywhere from 30 to 40 or 45 patients a day come through our respiratory triage unit in the ER. That is all patients that have respiratory symptoms that could be influenza, COVID, or other infectious agents causing their symptomatology. And again, that number oftentimes really picks up when we're seeing higher numbers of COVID cases come to the hospital. We're anticipating flu season this year is going to be more significant than last year, but still our flu numbers right now, fortunately, are very low. That's good news. We are seeing some flu numbers in the southern part of our state and our sister hospitals start to pick up. And from what we've typically seen, flu oftentimes comes from that the more southern parts of our state and the southern part of the hemisphere. We see those cases coming sooner than we oftentimes see here for whatever reason. Of the total patients that we have in the hospital right now, 81% of the admitted COVID patients are not vaccinated. And that has also been a consistent theme. The bulk of these patients have not received the vaccine in any capacity, and they are those that are most at risk of getting hospitalized. In addition to that, it looks like if you look at our breakdown of the age demographics, right now, 79% of those admitted are 50 years of age or older, and therefore only 21% of those patients admitted are less than age 50. That's a little bit lower number of the younger population that we have admitted at this time. Our testing rates for October month to date are at 11% positivity rate, which is down from September. We were at 16% of all tests were positive, and down from August, where we had 18% of all tests positive at that time. I want to just remind everybody, as Dr. Bell said, that obviously with the approval of booster vaccinations for Pfizer, which came out first, and the impending approval thoroughly for Moderna boosters, I want to encourage those who are eligible to get boosters to do so, especially if you are a healthcare worker and you are someone who is at higher risk of acquiring this infection than the normal population. Overall, we have about 60% of our employees here at BSA are vaccinated with the primary series. We opened up a vaccination clinic for those that needed and were eligible and desired the Pfizer booster last week. And we had a successful number of days with that clinic, vaccinating close to 500 employees and medical staff members during that time frame with the booster. There are some additional things, as we mentioned before, that we think are on the horizon in terms of helping to mitigate COVID-19 if you are infected. Obviously, there's very good data with the monoclonal antibodies And we continue to encourage folks to come to our urgent care center with a physician order to get monoclonal antibodies if you are known to be infected, close to the onset of the timing of your infection and your symptoms, most ideally within a couple of days. The sooner the better, once you know that or you have symptoms and confirmed COVID-19. So we can give you monoclonal antibodies if you qualify, which means you're a little higher risk to have a severe infection if you get infected. These have been very successful at keeping people out of the hospital. There is very good data to support their use. And please remember that that's an option for you if you are unfortunate enough to get infected and be in this category. We're also seeing that we still have a number of our employees that are getting quarantined because of infection. And right now we're at 15 of our employees are under quarantine, which is a much smaller number than we had been in the past. Remember, there was a time where we had 100 employees that were quarantined, which was a different day and a different time frame. So we're much happier that we're here now where the bulk of our staff is protected by the vaccine, some of them by previous infection for a transient period. We're starting to see some breakthrough infections, which means that folks that were previously vaccinated are getting infected. What we're seeing in our employed population is when that happens, it tends to be a very mild infection. We still have to quarantine them, but the infection tends to be very mild and we're not hospitalizing any of those individuals. And that, again, really has to be because of the protective immunity that they are benefited from with the initial vaccine series. As always, we are trying to really work with our staffing shortages on the nursing side in terms of fortunately, the RAC and state support we're getting with nurses and also contract nurses that we are hiring independently. It is an ongoing challenge to try to make sure that we have enough staffing to manage our inpatient population. And we're taking steps to make sure that in months ahead, we are going to have adequate staffing, even when we lose the RAC support, which is anticipated to happen probably over the next couple of months. So I think that really is the key here. I want to thank all of our medical staffs and our nursing staffs and support staff, ancillary, all those folks at both hospitals, or I should say all healthcare systems, the VA included, and our medical clinics throughout the community, who have been doing a fantastic job of managing our community in terms of this illness during this pandemic. Everybody has been really combining with exceptional efforts to keep folks healthy, to keep people safe. And really, it's something that we need to acknowledge whenever we're seeing those healthcare workers in the community. Please thank them for their hard work and efforts, because they truly are putting themselves at risk every day to help care for and manage patients who sometimes in this situation are extremely ill. That's all I have, David. Thank you.
Thank you, Dr. Lementier. We don't have Dr. Rodney Gonzalez today of the Amarillo VA, but we are happy to welcome Dr. Catherine Ewing, who's subbing Dr. Gonzalez today. She is nurse executive at the Amarillo VA. Dr. Ewing, welcome to the panel. How are you today?
Good morning, everybody, and thank you for this opportunity to talk to our Texas Panhandle and Eastern New Mexico veterans. This morning, our healthcare system is currently caring for 5 COVID patients, of which 1 is currently on mechanical ventilation. As previously shared, we are rapidly approaching our flu season, so I really want to remind our veterans to please remember to get their annual flu vaccines. Our clinical teams are already offering the flu vaccine. If a veteran has a scheduled appointment, please know that you do not have to come back and make a second visit. You can get your flu vaccine during that appointment. Just simply reach out to the nurse at your appointment. This is available on all of our campuses, Amarillo, Childress, Dilhart, Clovis, and Lubbock. So please take an opportunity to get your vaccine while you're at one of your clinical appointments. Should you not have a clinical appointment, please know that in Amarillo, we are currently holding a flu fair. It is every day this week through Saturday from 8:30 in the morning to noon. If you have a spouse who wishes to also get their vaccine, they can come with their veteran. please know that they should bring their Medicare card and or insurance card to participate in that program. And we'd like to give a shout out to our partners in that program, Texas Tech Pharmacy, who is assisting us with assuring that both our veterans and our spouses are getting vaccinated as we're entering this flu season. Finally, I'd like to invite all women veterans to participate with us tomorrow at 6 p.m. in a tele-town hall conference with Dr. Rodney Gonzalez. We'll be discussing women's health issues and how the VA can better serve our women veterans. This town hall will also be broadcasted via Facebook at our Facebook page. It is at VA Amarillo. So for those who are unable to participate, please join also via phone. Lastly, yes, all of our healthcare professionals have been instrumental in our efforts during this COVID pandemic, but I'd like to send a big thank you to our Amarillo pharmacy team, as it is National Pharmacy Week, and thank them for everything they do in our community for our veterans. Thank you for allowing me to fill in for Dr. Gonzalez, and I'd like to thank all of our veterans for listening today and for your service. Thank you, sir.
Thank you, Dr. Ewing. We'll now go over to members of our media who are in attendance. If you have a question for a panel member or the panel as a whole, that's completely fine. Let's go and start with Michael Cavello of the Amarillo Globe News. Michael, how are you? We'll go ahead and start with Michael Cavello of the Amarillo Globe News. Michael, how are you this morning?
Can you hear me now?
Yes, we got you. How are you, Michael?
Okay. I guess it double clicked. With the antibody treatment going on, you stated that it's taking people out of going to the hospital that would have had to go to the hospital. Do we have some type of percentages on that, or like what kind of, I mean, I'm pretty sure the data backs that up, but what kind of data do we have on that?
So and Mike, I don't know if you want to take it, I'll give a first blush at the prior data. So the original data on the monoclonal antibodies was back prior to Delta. Bear in mind that Delta is more infectious and seems to be causing more significant disease even in younger people. So the numbers might be a little bit different. The original data was that for every 20 to 30 people who were treated with Regeneron or one of the monoclonal antibody methods like that, that we were able to prevent one hospitalization that otherwise that person would have ended up at the hospital. So because obviously not everybody who gets infected has to go to the hospital, and we don't necessarily have a great feel for who are those folks who end up needing to go to the hospital and who don't. The true number with Delta is probably somewhere around there, but maybe for every 10 doses of monoclonal antibodies that we use to somewhere around every 30 doses of monoclonal antibody that we're preventing a hospitalization. If you look at the number of almost 600 infusions in the city infusion centers in the past month, you add in the massive number of infusions that have been done by the hospitals over the past few months, we've actually prevented probably upwards of 130 infections that would have ended up going to the hospital. So 130 hospitalizations. The average length of stay on somebody who has COVID and gets hospitalized, these are not short stays. We probably have an average hospital length of stay of somewhere around 6 to 7 days. So you take that 130, you multiply it by 7, and all of a sudden we have a large number of hospital days that would have been tied up, that we would have had nurses that were having to take care of those patients, doctors, pharmacy staff, our ancillary staff. All that adds to the stress and pressure on the hospital system. So we really think that the monoclonal antibodies have been very helpful. Dr. Lamentier, did you have something you wanted to add to that?
Yeah, I would say that is a good summary. I think it's critical to note that, again, we don't know what that number needed to treat is for folks that have Delta, because the studies were done before that, to Dr. Bell's point. I really think that number is probably lower than the initial studies had demonstrated. And we don't have exact numbers in terms of how many of those folks have translated to a hospital stay, but I can tell you from the providers in our facility that are managing these patients day in and day out, that is not part of the historical feedback from the patient. That is, if they're getting admitted for COVID-19, very, very, very few of these folks have had a monoclonal therapy in that short time frame after infection. It's just not happening. It's keeping them out of the hospital. We've administered about 2,000 doses, 2,000 unique patients with monoclonal antibodies since the outset of the pandemic originally, once the monoclonals were available, I should say. So that's a significant number of patients, and that's more heavily loaded on the back end here over the past several months, where we really had been churning out a lot of administrations. And I think it's been a very successful, well-tolerated therapy where we're not seeing adverse reactions, and we are seeing people, again, not translate to an admission.
And I guess I'll bring up the dreaded I word again. Are we seeing in the hospitals still a lot of people demanding ivermectin and stuff like that? And have you seen any studies that have changed anything at all on the thought process for this?
Well, since you brought up the question, Michael, I'm going to be happy to provide some feedback on that. So I'm glad you asked the question. Here's my response. We're still getting intermittent requests for ivermectin from patients and or families. Our response has been universal, and that is that it is not a recommended or approved therapy for COVID-19. And the reason behind that is because the data to support its efficacy in well-done trials is lacking. I recently spent some additional time critiquing and looking through the large meta-analysis that was done on ivermectin that has been published and recently submitted this past summer. And when I went back and looked at that trial, that really was looking at it really is a consortium. A meta-analysis is a consortium of many smaller trials that are put together to try to make conclusions in a more grand sense, so to speak, about a potential intervention or therapeutic. So inherently, the nature of a meta-analysis design is flawed in terms of trying to eliminate all sorts of bias and make sure that we're looking at a true cause and effect. So I want to start off by saying that. Secondly, when you look at the actual meta-analysis that was done this past summer when it was published, there are 24 trials that made up the content of the meta-analysis. And the own authors of this meta-analysis did an analysis that showed what types of bias were present in each of those individual studies. And there were only 3 trials out of those 24 that really, at the beginning of the structure of this, were without inherent bias. That's reported by the authors. So that in and of itself is a significant concern. And then when you look at what they call the quality of evidence, they do another statistical assessment to look at the quality of evidence. It's all rated low level in terms of the quality for every study except one, which was rated as a moderate level of evidence. So again, I think this is not surprising that the major organizations like the CDC, the NIH, the WHO, well-known and respected hospital institutions throughout our country, look at what the Mayo Clinic's recommending. Look at what the Cleveland Clinic's recommending for COVID-19. They're not recommending ivermectin. And it's because the level and quality of data is insufficient to recommend it. And yes, I'm very much aware that the NIH says that we do not support, nor do we speak against the use of ivermectin. And I think it's pretty clear why. The best place for discussions about ivermectin in the setting of COVID-19 are in better clinical trials. And again, I know that many of these are ongoing. We know that there's a lot of use of ivermectin in third world countries and other foreign countries throughout the world. And that's fantastic, which means that we're going to hopefully have a growing body of evidence to determine with a higher level of quality of that evidence if there's any beneficial effect of this medication or others. But for someone to suggest that we have that data now, I think that is an incorrect statement. And I also frequently tell our providers or folks or family members, whoever it is that's suggesting to me that we really ought to be thinking about ivermectin, to please bring forward the additional new evidence that you've found, because I'm happy to have that reviewed and reviewed by the committees within our health system that look at these trials and decide if something should be added to the therapeutic armamentarium.
Thank you. That's all I had. Thank you very much for that.
Thank you, Michael. Let's now go to Aaron Langston at KAMR Channel 4. Aaron, how are you today?
Pretty good. How are you?
Good, thanks.
First question is, how soon are we expecting that once the booster shot from Moderna is approved and the 5 to 11 vaccines are approved, that we could start getting those doled out here in Amarillo?
So it kind of depends on what time of day. So, traditionally those are approved late in the evening. So I would anticipate either by the next day or early the next. So I would say very quickly, those vaccines would be available here in our community.
All right. And do we have the availability of the doses already, or is that something that might take a day or two?
They would need to be shipped to us.
All righty. And once the kid vaccines are approved, is there any plans to potentially have special clinics for parents who are wanting to get their kids vaccinated?
Yeah, so we'll certainly be offering those at the public health department. And then I know the state is making an effort to include pediatricians and other places that kiddos would be getting their vaccines.
Alrighty. And we're seeing good results with the monoclonal antibodies. And we have the hospitals giving them and the clinic downtown. Is there any plans to expand that or make that more available to people?
Not right now. We have lots of appointments that are available. And so we've got plenty of capacity, certainly at the city clinic. And so if we can certainly accommodate more patients there at that location. So I don't know that we need another location because we have lots of availability.
Alrighty, I think that has me covered. Thank you very much.
Thank you, Aaron. Let's now go to, if I'm not mistaken, Kevin Welch of KFDA News Channel 10. Kevin, how are you?
I'm good, Dave. Thank you. So can somebody tell me approximate numbers of staffed ICU beds that are available now?
I can't speak for Northwest, but as I mentioned this morning, looking at our total ICU beds, we have 48 beds in our ICU proper. 43 of those this morning were occupied. We also have an intermediate care unit that we can vary the bed availability from 20 to 30 beds, depending upon staffing there, which we can have ICU level patients managed there, and we do today. Of the 18 patients we had in the IMCU this morning at intermediate care, 5 of those were ICU level patients. So we had a capacity to take additional ICU patients, but it wasn't great, as you can tell. Of course, that's the beginning of the day. We oftentimes are getting patients moved out and transitioned down to a lower level of care, and that opens up more beds for us. Our overall census has been a little bit lower of late, and therefore we've had less demand on some of those ICU beds in the non-COVID population, but it is still a day-to-day assessment of what we're doing as far as other elective surgical cases that may need to be delayed or postponed, and also determining what patients can be managed in a non-ICU setting.
Okay.
And
Casey?
I
Oh,
don't
go ahead.
have Northwest numbers, so I apologize.
That's what I was afraid of. No, that's fine. Casey, do you have any plans for operational ramping up when the boosters get approved, since the city gave out a lot of Moderna shots before?
Yeah, that's a great question. So, there's lots of places where people can get vaccine now, which wasn't the case when we opened up the clinic at the Civic Center. So patients can, take their card and get their booster dose at Walgreens or CVS or their doctor's office or, any pharmacy. So lots and lots of places have vaccines. So we'll be providing booster doses, but we won't have access to a larger space like the Civic Center. So we'll certainly be doing that, but we have lots of opportunity here in the community to give vaccine. So, and that just wasn't the case when back in December and January when we opened up the Civic Center clinic.
Okay, and any plans for dealing with younger kids getting approved?
Yeah, absolutely. So we will have, we'll be able to operationalize that through our vaccination department. And so we have nurses who give kiddos their vaccines every day. And so I think they'll do a really great job with that.
Okay. And Dr. Bell, can you elaborate a little bit more on when you said that you were optimistic about the holidays?
Sure, absolutely. So we anticipate that our numbers in both community transmission as well as hospitalizations and pressure on the hospital will continue to trend downwards. And we've been seeing this slow trend. Our numbers are drifting down. We're not where we want to be, but we are certainly things are looking much better than they did, say, 4 to 6 weeks ago. We would anticipate those trends are going to continue. Once we have a surge, there's a pause after a surge because we have both the built-in resistance to disease from those who have been vaccinated, as well as the resistance to disease from those who have been actually infected. And we've had a lot of people infected here in the past couple of weeks. That creates a space where there's fewer people available to be infected for some period of time until that immunity starts to wane. And it's worth noting, again, when we talk about breakthrough infections, we usually are saying that in the context of someone who is vaccinated 6 or 8 months ago. The reality, of course, is that we also have breakthrough infections from people who were infected 6 or 8 months ago. So we have a time period that there's going to be a large percentage of the population that is going to have had either vaccination or recent infection. And that means that we're not going to get as much transmission during that pause. That pause looks like it's going to be in that November, December timeframe, which is kind of where the holidays are. This does not give us a free license to go and everybody go down to the public square and lick the stair rails going up the courthouse. This is it's an opportunity for us to be able to make use of that time for people to be vaccinated, for people to be able to enjoy their families with a higher sense of security, for people to be able to go get their Christmas shopping done. Again, we're all looking to live life while we're learning to live with this virus that's going to continue to be here among us. And so I think that there is some optimism, though, that those numbers will be in a good place come Thanksgiving and Christmas.
And Kevin, I am super excited about the new age group that's able to be vaccinated. I think it's a great thing. The only thing I'm sad about is that our youngest is still going to miss that cutoff at age, she's 4. And so we're not quite old enough at 5, but we'll get there eventually. So I am really excited that that we'll have a new age group that'll be able to be vaccinated.
Good to know. That's everything. Thank all of you.
Thank you, Kevin. Let's now go to David Furtado of KVII Channel 7. David, how are you?
Doing pretty good. How about you guys?
Good, thanks.
Good, good. Hey, I just had a quick question. I know Dr. Bell alluded to the gradual and decrease of the spike as we kind of head into the October months, October, November, what have you. And I can kind of see that here on the dashboard. So my question is more so, we are worried about the flu this year as well. So what are you guys expecting as we see this gradual decrease of COVID-19? Are we going to see, I guess, a more a spike? Is it going to be more of a flu season rather than a COVID season, since it seems like we're kind of ending our spike of COVID? Is that kind of what we're thinking this winter might be, more flu cases rather than COVID cases?
Well, again, the crystal ball is always murky, right? So I think that our COVID numbers will probably be down in the end of November and December. I think things are going to look good. Our flu numbers historically are at their peak the first or second week of February or so, late January, early February. And right now, it appears that would be a reasonable time to expect a flu peak as well. Now, sometimes we do get earlier flu peaks. We want people to get their flu shot now. Don't wait until January to get your flu shot. But the one potential thing that we have on the horizon we have to think about is that if we were to take September and we add 6 months or so to that, the time in which we would start worrying, well, maybe we're having waning immunity from prior infection from COVID, we're really looking at that February, March timeframe as being the time that we would start to see more susceptibility to COVID infection coming online, at the same time that we would historically have our most likely time for a peak in our flu season as well. So I would guess that through the end of the year, we would potentially see some increase in flu over the course of the rest of the next few months, with a continual downtrending in COVID. But coming into the 2022 season, once we get into February and March, we have an increasing risk of COVID, maybe not as high of a surge as what we've seen recently, but some increase in that COVID risk at the same time that we would see our historical risk of flu going up as well.
Okay. And kind of my other question is we've discussed this probably several times. There's this idea that COVID is going to be an endemic disease. It comes back year after year kind of deal. So, as we're starting to see it looks like, as with Delta being so transmissive, it was the spike hit a little bit earlier. So do you think, in the next 3 or so years or whatever, it could be a situation where we have the COVID months and then we would have the flu months? Could that be a situation that we could run into?
Yeah, that's kind of the thought, is that eventually it'll achieve this seasonality, and basically it's complex how that happens. But what we would anticipate is that over the course of the next, say, 2 years or so, that we'll start to see a more predictable seasonality of COVID, where during the wintertime months, we have more COVID. During the summertime months, we have less COVID. There's probably, different than the flu, there's probably going to be risk of isolated outbreaks of COVID in certain places that are places where people are gathered in intense situations, even if it's out of the typical COVID season. So it would not be a surprise if we have a discussion like this in the summer of 2024, that we're talking about, hey, we're looking at going into our flu COVID season. Everybody needs to get their flu shot and their COVID booster, or whatever the case may be, whatever the data shows is necessary. And that we look at something that becomes just part of the pantheon of viruses that we deal with every year.
All righty, I'm all out of questions. Thanks so much for answering, Dr. Bell, and I hope everybody has a wonderful day.
Thank you, David. That's the end of our questions from the media for today. I want to thank all of our panel members who took the time to provide this information to the Amarillo community. Once again, this is David Henry. I'm the Communications Manager for the City of Amarillo. We'll see everyone next time. Thank you.